When Dr. Nandita and I were just discussing, and she said, why not we have a program in which we talk of the greatest desire which humans had, to have their own babies. And it so happened that today we talk so much about third-party reproduction. But why not talk about something which actually pertains to human existence? And that was the theme on which we are going to have 4 episodes. The first episode is where Madam is going to speak about poor responders, and I will speak about azoospermics, how could they have their own babies. And in the second one, she's going to speak about recurrent pregnancy loss, and I'm going to speak about the male part of it. The third program is going to be on genetics, where Madam will discuss and unravel the problems of genetics in the woman and how they can be solved to have their own baby. I would discuss the infertile man and genetics. And the fourth is going to be about which, in fact, leading work has been done in this country by Dr. Nandita, which means the frozen cycles, I mean the frozen eggs. And that's what she's going to talk about. In fact, we all know that Diana Hayden, I think, ma'am, Diana Hayden, she had a baby from frozen eggs. And I'm going to discuss what to do for the uterus so that a uterus which probably was not right enough to have a baby could be used instead of a surrogate. So we have 4 episodes, and the first one is going to begin with this. I would request Sonal Madam to please introduce Madam.
Good evening, everyone, all delegates and our guest. I welcome you all to this unique series of webinars on how to get own babies. First, Dr. Nandita Madam will be speaking on how to give poor responder their own baby. She's director at 9 Bloom IVF Centers, professor at D.Y. Patil Medical College, president AMOGS 2020-22, vice president ISAR 2020, and she is former president FOXY, MOGS, IAGE, former chairperson MSR. She has written more than 150 chapters and received more than 18 awards. To her credit, she has 61 orations, delivered more than 1,000 talks, and she is recipient of Bharat Gaurav Award, IMA Award for contribution towards medical field, IMA Empowered Woman Award 2019, Frost and Sullivan Best Practices Award for IVF, and Woman Super Achiever Award 2019. This is a brief introduction of Dr. Nandita Madam. Over to you, ma'am.
Hello, everybody. Thank you, Dr. Sonal, for that wonderful introduction. And I think Sunil and the introduction was fantastic. You know, we were sitting and chatting, and actually I get a lot of patients. And, you know, one of my patients said, Doctor, I don't want egg donation. I want to have a child which is my own. And that is something that we've been working on for ages. And I think in all IVF practice, these are the difficult cases. You know, I always tell the girls that if you want to go to Vaishno Devi by helicopter, take the egg donor and you'll reach there, you'll get your goal. But if you want to climb up, that's where the challenge is, and we will help you. And I think it's so very important. A lot of women want to have their own children, and today you know, we have so many treatments that are available that it's really fantastic what we can give these girls. We are going to talk about poor ovarian response, and I think a lot of women who come to my clinic demand that they have their own child. And if you see, I think the Poseidon groups that were formed actually describes the ovarian reserve beautifully. And it's very easy to remember. Poseidon 1 and 2 are all young patients, remember that, and Poseidon 3 and 4 is older patient. So young patients less than 35, but with good ovarian reserve. You know, they have a AMH which is more than 1.2, IFC which is more than 5. But when you stimulate them, you get really less eggs. So the subgroup 1A is when you get even less than 4 eggs, and subgroup B is 4 to 9 eggs. In Poseidon group, we know that the AMH is low, the AFC is low, and you get less eggs. But these are all younger than 35. And the group 3 is the similar group. Group 3, the first part is older than 35 years and do not have a poor ovarian reserve, but the AFC and AMH is good, and still they give a poor result. So this is the way you describe and you divide the patients into two. Now, I'm jumping straight to management because I really want to hit on the important points that are necessary. Maximizing ovarian responses. When I scanned the literature, there were multiple things that were there. High dose gonadotropins, all preparations are equally good, protocols which can be implemented, antagonists, mild stimulation, long agonist protocol, ultra short agonist protocol. What I would like to discuss is what I do in these patients. And believe me, I have delivered 5 patients, 40 plus with AMHs 0.7, 0.5 in the last 3 months. And that is only with patients' perseverance. And that is what I'm going to tell you all what I have done in these patients. So the antagonist protocol is the protocol of choice which I have. My first protocol is always the high dose protocol. You use HMG or you use recombinant FSH. I prefer the recombinant FSH. And I start with really 450 international units and go on and add antagonists to it. So this is my protocol of choice. If in that protocol I get 1 or 2 eggs only or 3 eggs, then I switch over to mild stimulation protocol, which is clomiphene citrate for the first 5 days and gonadotropins from day 3. Sorry, not mild, but a modified antagonist protocol. But I add clomiphene to the same protocol which I've used before. And the third choice is a mild protocol where I use clomiphene citrate / letrozole for the first 5 days. Then I use gonadotropins for the next 5 days. So these are the protocols that I'm using for all these patients. And recently I've also started using dual stimulation. So dual stimulation is what? You use gonadotropin antagonists, you use gonadotropins and antagonists, then use a GnRH analog for trigger. And once you give the trigger, after 4 days, I give 2 days of letrozole and then start immediately with gonadotropins. And it really is, I will show you some studies, which are latest studies, which show that you get better eggs. But what happens is the time frame is shortened, and in 1 month, you can get 5 eggs at least from these patients, where you get 2 and 3 or 1 and 3, that kind of a thing. So there's always a little more eggs in the second half of the cycle. And of course, what I do for these patients is embryo pooling. So I collect 1 embryo, 2 embryos, whatever I get, pool them together, and then start putting them back again. And now what we're using is HCG or the dual trigger. We have started using dual trigger where we give HCG plus a GnRH analog as a trigger for this cycle. And this is the protocol that really works very well in ovarian reserve. So dual trigger, this is a July 2020, very recently published in Fertilities, in PLOS One, sorry, and it showed that in 384 cycles, in the Poseidon group 4 patients, they received dual trigger, 194 received dual trigger, and they retrieved more oocytes, more M2s, fertilized oocytes were more, day 3 embryos were more, and top quality blastocysts was also more, and significantly higher CPR and LBR in the dual trigger group. So definitely in older patients, the dual trigger does help. Another study which I came across when I was, researching for this talk is letrozole for the entire 10 days. So letrozole co-treatment during the entire stimulation course improves ovarian response and I. Sorry, I think I got disconnected. Can you take me in? Am I in? Hello? Hello?
Yes,
Yes,
ma'am.
ma'am.
Yeah, you are.
Sorry, I think the Zoom just got disconnected. Okay, so now we come to the part, what are these adjuvants? There are lots of adjuvants used in poor ovarian response. And these adjuvants are, I think the commonest one which we use is DHEA and testosterone. And one minute, let me just, okay, anyway. The commonest ones are DHEA and testosterone. And the mechanism is uncertain. And it's speculated that it increases the serum concentration of IGF-1, which may improve the response to gonadotropins. So it improves steroidogenesis as a precursor for estradiol and testosterone, creation of a PCOS-like characteristics and increasing their age. In fact, I remember there were a couple of patients who took DHEA, disappeared from our practice because they could not come back. And when they came back after a year on DHA, they actually had a PCOS-like pattern in their ovaries. These are especially patients, where probably autoimmunity or there is some kind of a endocrine disruptor which has happened and that has gone away and the DHA works. DHEA testosterone also acts as a pre-hormone for follicular fluid testosterone, reduces age-related aneuploidies by affecting the meiotic chromosomal segregation. Now, we have come across studies of DHEA reducing aneuploidies. It is mainly because of the meiotic chromosomal segregation where it acts on, and it increases the antral follicles and the AMH level. So what is the dose of DHEA? Ideally, should be started 3 months. Sometimes we give it even 1 month before starting IVF. And I continue it till the trigger, and the dose is 75 milligrams per day. And the Cochrane reviews, where there were 7 RCTs in poor responders, I think the number was something like 1,000, pooling the RCTs, it showed that there is an improved live birth rate and DHEA pre-treatment. This was, of course, Nagels in 2015. It's an old meta-analysis. The evidence quality was moderate. But remember that what I do is I continue DHEA afterwards also, because I feel that the androgen is even required in the endometrium. And I just read an article which is in Press in Fertility Sterility that DHA in older women improves the endometrium. So I think it's worth giving DHA in these girls, especially where the androgen levels are low, and that is what is causing the poor response. It helps your endometrium also. The testosterone application, this is something which I've started using. I use it for 1 month before my IVF cycle. It's a transdermal application, either gel or patches. One of the company I think has the patches, one has gel. The dose is about 10 to 12.5 milligrams per day. And you can give it for 2 to 4 weeks in the previous cycle. So if you don't have too much time to give DHEA, you can use testosterone gel. The recent meta-analysis 2019 included 7 trials, and it suggested that testosterone may increase the live birth rate and CPR. And in fact, there's not much robust evidence to say that use DHA, use testosterone. But there is this new trial, the T-Transport trial, that aims to provide robust evidence regarding the possible beneficial role of transdermal testosterone in controlled ovarian stimulation with ART. I think this is something that we are looking at, and we should have good results in this patient. The growth hormone. Now remember, adjuvants, I mean, all of us use it, but RCTs are not available. But we all have seen that in our practice it helps. So I think that is where you need to take it from. You need to identify the patients which will benefit from the testosterone, which will benefit from the DHEA, and use it. The growth hormone receptors are located everywhere. oocytes, follicular somatics, etc. The growth hormone acts on receptors and is responsible for the pre-antral follicular growth and differentiation. And growth hormone further stimulates small antral follicles to gonadotropin independent stages as well as maturation of the oocytes. The dose that I use is 4 to 12 international units per day. You can either use it for 1 month, or how we use it in our practice, because very expensive. We use it at 8 units, international units, from day 2 of the stimulation till the day of the trigger. And these are different studies. The meta-analysis and the systemic review has shown that it causes an improvement, but again, there is no increase in live birth rate. But there is a study now, which was in 2020, which says that those patients who have a deficiency of growth hormone would definitely benefit from addition of growth hormone and give better results in these patients. What about melatonin? Melatonin is a wonder drug. It reduces the oxidative stress everywhere. You know, there's oxidative stress in the peritoneal serum follicular microenvironment because of poor ovarian reserve, and that can result in poor oocyte quality. The mechanism is unclear, but it is said to reduce the oxidative stress, acting like a free radical scavenger. Meta-analysis and systemic review of 10 RCTs, which were recently published in 2020, significantly increases the CPR, but not the LPR. Increases number of M2 oocytes and good quality embryos. I think every embryo that we get is very important, and that's why I've been using melatonin for the last 10 years of my practice. Arginine is another drug which is being used. This particular Cochrane review, 50 trials including 6,000 women. Nitric oxide is how the L-arginine acts via intra and intercellular modulator in many biological processes, especially the ovarian physiology. Low quality evidence showing improvement for subfertility. Insufficient evidence to draw any conclusions, but in a few studies it has shown positive, in a few studies no. So arginine is something that all of us use because we know oxidative stress. Definitely it helps if you give an antioxidant. Estradiol pre-treatment. This is something which has been promoted since I think IVF started. That what estrogen does is it kind of gets the cohort together. So when there's irregular growth of the follicles, this coordinates the follicular growth. Advantages are milder FSH suppression, lesser reduction in ovarian antral follicles as compared to OC pills, and can be used where OCs are contraindicated, does not affect spontaneous fertility potential also. If the patient is wanting to try, she can do that. And 4 milligrams per day from day 20 to first day of the menstrual cycle is the dose. Now we come next to the experimental part, the exciting part, which is giving results. And this is something that we need to look at. Ovarian rejuvenation techniques. So let's look at the PRP, platelet-rich plasma. Okay, so the body's first response to tissue injury is to deliver the platelets to the site. And through these platelets, there are many factors which are secreted within 10 minutes. That is the VEGF, the transforming growth factor, the platelet-derived growth factor, the epidermal growth factor, the connective tissue growth factor, fibroblast growth factor, insulin-like growth factor, interleukin-8, etc. Now, we've heard all these in different sites for our ovarian physiology. And we know that these are necessary for ovarian, for follicular growth, for implantation, etc. And that is how PRP is useful. All these factors are delivered to the site and they promote healing by regulating stem cell migrations, proliferation and differentiation, and promote extracellular matrix accumulation. So intra-ovarian PRP, this is a 2020 study in 311 patients, 201 who attempted IVF post PRP. So you give PRP and 2 months, 2 weeks or 3 weeks later, you can actually start the stimulation. And out of these, you can see that 23 women conceived spontaneously and 57 women who underwent ET, 13 had live births. PRP can be used in women with premature ovarian insufficiency as an alternative experimental treatment option. Remember, you have to explain to the patient that it's experimental. We have started injecting PRP transvaginally. You know, during the pickup, what we do is we prepare it and we inject it during the pickup when we know that she's a poor responder. And young patients with low AMH, and currently one patient is pregnant, and we have, presented this paper in the last year of ISAR conference. Stem cells. I think stem cells is a wonderful innovation that has come, and there's a beautiful paper from Pelser's unit, that is Herais. She's done work in the previous paper. I can't see the thing, but I think that's 18, and this is the paper which is 2020. It is amazing that, the second paper, human bone marrow derived stem cells, these were taken from a patient and they were infused into mice. There were two types of mice. One were immunodeficient mice who were given, who had poor ovarian reserve. And the other group was the mice where the ovarian cortex of the patients was transplanted into that mice. And in both the mice, they were given injection of PRP. And what they found was follicles actually increased and growing. So bone marrow stem cells actually grow there, and they induce growth of the ovary. And this is something that is really being used now, and there are lots of trials happening, and we've also done a couple of patients where we've injected the bone marrow stem cells. Now remember, if you want good bone marrow stem cells, then you must give GCSF subcutaneous to the patient at least 4 days before. So 4 days, 2 days, and then 2 GCSFs, and then you go for the bone marrow aspiration. It really increases the amount of bone marrow stem cells, the GCSF, and you get better stem cells. The other technology is ovarian in vitro activation. That is a PTEN inhibitor and a PIK3 enhancer. I was just talking to my daughter-in-law who's a cancer patient, and she says, yeah, we use PIK3 inhibitors. So PIK3 enhancer is for proliferation, for producing more oocytes. That is how ovarian in vitro activation is done. So what you do, you take a biopsy and you incubate it with PTEN and PTEN inhibitor and PIK3 enhancer. So it stimulates the signaling and the activation of the dormant follicles. And then these ovaries are regrafted and allowed retrieval of mature oocytes. So this is another technique which is being used, that is ovarian in vitro activation. Mitochondrial rejuvenation, or the augment technique, is also, which is known, but it is $25,000. But I'll tell you how it's done. So you take a small biopsy of the ovary, either laparoscopically, and then you freeze it and you send it to America. In America, what they do is they create mitochondria from these oocytes, and these mitochondria are then frozen and they send it back to you. So when you're doing ICSI, as you can see in the picture, you inject the sperm with extra mitochondria. You know, this is known as mitochondrial rejuvenation, because older eggs have older mitochondria, lesser mitochondria. So you want more mitochondria so that the oocyte is activated, it's rejuvenated, and it performs better. So this is known as the augment technique. You need to take the woman's egg so that there is no HLA typing needed and all that. Then spindle transfer is another way of mitochondrial rejuvenation. So what Nuna this is Johnny Zhang actually, but Nuna Costa and Johnny Zhang together, what they did was, you can see that this is a donor oocyte. So you just take a fertilized spindle and pick it up and put it into an egg where the nucleus is removed. So the egg, the cytoplasm with the young mitochondria is there, and you insert the nucleus of the older patient. So the genetic material is the same, but of course the cytoplasmic genetics is of the donor egg. So this is a treatment which was carried out, and a baby was born, a baby with 3 mothers, they said. The genetic material is of the donor, the genetic mother, and the genetic father. This is Nuno Costa, where what he does is, the pronuclei are injected into the egg. Okay, what about technology? The spindle check. Now, in these patients, when we have hardly 3-4 eggs, so we must inject it properly. As you can see in this film, it goes dark and you can see the spindle. Can you see that luminescent spindle which is there at about 8 o'clock position? So when you do ICSI, you should identify the spindle and so that you don't damage it. And that is what is important. So once you've identified it, you fix the egg, and then you can again go back to your normal light and perform the injection. So now you know that you're away from the spindle and you cannot damage the egg by damaging the spindle. So this is how technology is used, especially in my cancer patients. Those who have very less eggs, I use this technology. And this was a beautiful paper in January 2020 that poloscope can actually be used as an additional tool. And today we are having all artificial intelligence, deep learning, all these aspects. And believe me, we may not have to do invasive PGD anymore after some time. So in this case, and in this study as a scene, that with the poloscope, the spindle morphology could be classified into 5 parts. You can see in the picture, A is the normal spindle, which you saw in that previous egg, which I showed you. B is dysmorphic. It's not homogeneous at all. C is translucent. D is telophase, and E is absolutely not visible. And the study showed that A and B are the euploid. Generally, they are euploid. So I think a combination of embryoscope, the time-lapse photography, combination of poloscope, etc., will be able to help us weed out the euploid, weed out the abnormal embryos and keep the normal embryos. The other new technology is, of course, pre-implantation genetic testing. Now, in these patients, especially my 40-year-olds, I found this technology very, very good. So PGT has really advanced a lot, but you have 3 aspects to PGT. PGT is PGT for aneuploidy. That means you see the number of chromosomes are correct or wrong. The 22 chromosomes plus XY. If there's any monosomy, there's any trisomy, it's all picked up by PGT-A. PGT-M monogenic are, familial disorders. You know about it before, like hemophilia, sickle cell, or even BRCA1, BRCA2, Lynch disease. All these are known beforehand, and you can identify them by using the PGT-M technology. And PGT-SR is again structural rearrangements like Robertsonian translocation, unbalanced translocations. Now, these are also known. So M and SR is known before, and you have particular probes to identify those problems in those patients. But A is when you do a general screening to screen aneuploidy, and especially in older patients, we know. And do you know that once you do PGT, if the embryo is euploid of a 45-year-old, she has the same pregnancy rate as a 25-year-old. So I think this is a fantastic technology which helps. And PGT was done in poor responders, and pregnancy rates in the poor ovarian reserve group was really high, and miscarriage rates were 17.5%. So PGT also suggests a decreased effect of advancing age on pregnancy and miscarriage rate for women above 40. So it's really worth doing it. Now, there is a new thing which we are doing in our unit. And that is something that you can really think of, because here we are not damaging the embryo. So the culture medium is taken. So if you can see the first picture, it's an oocyte. ICSI is performed on that oocyte. Then it is kept in a dish to become a blastocyst, that is day 5 or day 6. Then this culture media of the dish is collected into the pipette. And then that is, whole genome amplification is done by the Malbec system. And then a library preparation for NGS, and NGS does the reading of the results. So this is as simple. You don't need to biopsy. You just need to take this. So it's non-invasive, it's easy to perform, no sample loss, high sensitivity, it's flexible, and even artificial intelligence can be employed in this. Now, this is something that I would like to read. NICS depends on the DNA that is released by the entire embryo. That means, Maharaj, pani dena please. So entire embryo, that is trophectoderm and the inner bars. When you do a biopsy, you're only biopsying the trophectoderm. And this DNA is released into the surrounding culture media. NICS increases the chance of getting sufficient amount of DNA to amplify to get conclusive results. While PGS depends on the DNA that is extracted from 4 to 5 trophectoderm cells only, which are biopsied. And if the biopsy is not done properly, it may result in killing biopsied material and causing degradation of the DNA and hampering the quality of results and reaching an inconclusive data. So NICS definitely has its advantages. In fact, we've done some preliminary work. We've done 90 embryos, and these 90 embryos, first NICS was done, and then we also biopsied them because we want to validate our system, and 80% concordance was obtained. So we had, out of that, we had patients, of those 90 embryos, the patients were for more than 2 failures, up to 7 failures. And pregnancies were achieved in 15 patients, and miscarriage rate in 2 out of 15. I know the miscarriage rate, but I feel that as we go more, have more cases, the miscarriage rate will probably drop, or even we will realize that the miscarriage may not be due to chromosomal abnormalities, but may be due to maternal factor. So this is something that you have to remember when you're using technology. Then bioconstruction. My son was asking, Mom, why are you putting bioconstruction in this? I think it's very important for women who want to have their own child with their own egg. Artificial ovary by Susan Paws at Denmark in Esri 2018 it was done. An artificial biobag, human stem cell implantation. This kind of bioconstruction we know has happened. But artificial ovary is something that Octay has published in 2016. I heard Susan Paul in 2019 in New York at a conference. But Octay has published 2 pregnancies in cancer patients where the chance of metastasis was very high. So what they do, alloderm is actually used in cosmetic surgery. It exists. It's a decellularized human extracellular tissue matrix. And so what they do, what Octay did was, he took this alloderm or ECTM, and he took the ovaries from the cancer patients, where the ovarian metastasis is very high, and he decellularized completely, so that there were single primordial follicles which were just floating. Those primordial follicles were taken and put on this matrix, alloderm, and ovary was grown and follicles were prepared, and this was put into the, I think he keeps it outside for 2 weeks, and then he puts it into the body, puts it into the body, and patients had IVF stimulation, and they conceived and delivered 2 babies. So it's a fantastic technology for cancer patients who have high metastasis, but who want to have their own genetic child. I think today's talk was all about going all the way out so that you don't have to go for egg donation. And I think that is amazing, and that is what we are looking at to help people get their own baby. So I would like to end my talk by saying that adjuvants play an important role in improving results. So DHEA, testosterone, arginine, melatonin, even CoQ, I've forgotten to add to it, but CoQ is also something which I'm using in these patients. Then dual trigger is something that I've started giving now for poor responders. IVF or ICSI results are the same. So whether you do IVF or ICSI doesn't matter. I do ICSI. Offer all the available options to the patient. Future looks promising where the need of oocyte donor may be eliminated completely. So I think there is a lot of research going on to prepare gametes in the lab. And they have been prepared in the mouse, and I think soon we may have that too. So thank you very much. And I think, Sunil, thank you. I think it was great that we really put our heads together, and these patients who keep coming to me and telling me that we want to have our own child, please let us, we don't want any, egg donation. I think that's wonderful and that's fantastic. So thank you very much. And I hope it wasn't too long.
It was,
Thank you, Nandita ma'am. Sorry.
yeah, thank you very much. It was just perfect, number one. And number two, they actually deserve it too, because when they come to us.
Yes.
So
It's so
thank
much
you.
pleasure to give them a child which is their own genetics.
I know.
So thanks, Nandita ma'am, for giving us very insightful and lecture with practical points for the ovarian stimulation, as well as the recent updates and what will be the next level of IVF in future. We feel that all our viewers must have been benefited with your talk. With this, I welcome Dr. Sunil Jindal, sir. He is Scientific Director, Madhu Jindal Memorial Trust, Baby Center, Meerut. He is Vice Chairperson, Delhi ISAR, Delhi IAGE. He has to his credit many publications and presentations. He has written more than 8 book chapters, over 200 national and international presentations, and more than 75 awards. His special interest is andrology, gynecological laparoscopic surgery, and ART. I welcome you, sir, to deliver the talk on how to get baby in azoospermic male.
Thank you very much. Thank you very much, Dr. Sonal, and thank you very much, everybody. And thank you very much, the audience, because if you ask me how it started, of course, with a discussion, but I remember about 14 years back, there was this father and son who came to me, entered my clinic, and the father asked me, "Are you Dr. Sunil Jindal?" I said, "Yes." He said, "This is my son, and he had cancer when he was a young child, and I took him to Mumbai, and there was one doctor at Vani because of which he's living." So I asked him further, "Yes, please." He said, "Isko iska bachcha chahiye." I really did not know what it was, how it was. He was a cancer survivor, a young boy who had got married. And for the father to come and say this, and for examined him, I felt a bit weird because, the language was not very comfortable. But I could understand the anguish which he had. So we went ahead, did a micro TC, took out some sperms, got 5 sperms. We never expected that we'll get embryos, got embryos. Put them in, never expected a beta SCG, got a beta SCG, got a cardiac heartbeat, and finally gave birth to 2 boys, whom he so beautifully named Love and Kush, which are there. And the realization that all these people who are told for a donor sperm can get their own sperm becomes very, very, it became something which I felt about. And I was discussing with Dr. Nandita the same thing. And while discussing this thing, she came up with this too, that why should these people not be given their own babies? And we all know that about 60 to 65% of azoospermics can have their own children. So based on this, I will just start my presentation. And so if we go on to the presentation, there are just a few key concepts which I want to talk to you about. The sperm count is going down in this century. It is estimated that the sperm count in the human male has gone down to 50%. New diagnostic tools have come out apart from the semen analysis. Antioxidant supplementation has become a very hot issue. Today, a lot is available for azoospermic men, which I would be talking to you about. And biological fatherhood is possible in even the worst case scenario. Spermatogonial stem cells represent a novel source of both reproductive and regenerative medicine in the future. And I will discuss with you of where are we now and what would be there in the future. We all know the semen analysis, the way the WHO 2010 has come to a level where this is the semen count. But before that, there is one thing which I would like to say, that the threshold values of semen analysis have an acceptable specificity but low sensitivity for identifying the males and their fertility. Therefore, caution should be used in interpretation of results in relation to the WHO manual reference values. So this is just to make you understand that the semen value per se as per the WHO criteria does not tell us whether the man is fertile or infertile. It tells us that his range is in the range in which 95% of people are able to get a child. But it does not tell us the sperm functionality. And there are three basic things which have become very important now, which are out of the purview of today's lecture, but they are sperm DNA integrity, reactive oxygen species, and Y chromosome microdeletion. So where are we today? The recent advances have been sperm function test, microsurgery, and genetic diagnosis. DNA fragmentation, we would talk about in the next lecture. Y chromosome microdeletion, we would talk about in the genetics lecture. But what I would talk to you about today is azoospermia. So azoospermia is going to be in three areas. It could be pre-testicular, where there is a deficiency of LH and FSH. And because of this deficiency, there could be less of action on the testes and the patient may be azoospermic. It could be testicular. Primary testicular is when the problem lies inside the testes, or it could be post-testicular in the form of an obstruction anywhere over here. So an obstruction anywhere over here will be post-testicular. In the testes will be testicular. Before that would be pre-testicular. Very simple. Obstructive is going to be post-testicular. The testes is producing sperms, but it is obstructed, so sperms are not there. Pre-testicular or non-obstructive is when there is a sperm production deficiency or absence. Now, azoospermia is not synonymous with sterility, and complete absence of sperms is seen in 1 to 3% population. And it constitutes about 10 to 15% of male infertility. Now, what does this mean? Why am I saying this? When patients come into my clinic who are azoospermic, they are depressed, apprehensive, and the word I would use is they feel small, especially when they come with their families and they have to say that they don't have sperms. It's a very funny feeling for them. So they need to be told that, my friend, you are not the only person. 1 to 3% of human population doesn't have it. So it is nothing like something very abnormal. But because people don't share this with each other, people don't know about it. And these are men who need a lot of tender loving care. I've heard a lot of lectures of recurrent pregnancy failure, where they say that you give tender loving care to these and that's what they need. But azoospermic men need a lot of tender loving care. Now, it could be of two types, obstructive. And in case it is obstructive, there would be a normal testes with an endocrine profile, and there is going to be a mechanical blockage. And spermatogenesis in these patients is normal. In non-obstructive, there could be a spermatogenic failure where the FSH and LH are high and the testis is small, and there is a disruption in the spermatogenesis. And in hypogonadotrophic hypogonadism, there is a decrease in the FSH and LH. They are small testes, and there is poor virilization, and the system is disrupted. Why do you need to know it? Because the treatment of both is going to be a bit different. Now, there are two algorithms which I would like to show to you, which are very important. In case the semen has low volume or the pH is less than 6.5, examine the patient. If the vas are palpable bilaterally, there is a possibility of ejaculatory duct obstruction. Do a transrectal sonography. And in case there is an obstruction, you could do a Tourette procedure to open up the blockage. But in case the vas is bilaterally not palpable, it could be cystic fibrosis, then surgical sperm harvesting is the only answer. Now let's move on to another category where the volume is fine and the pH is more than 7. You do a hormonal profile, you examine the patient. If the testicular size is normal or could be a bit subnormal, and the FSH is normal, this is suggestive of obstructive azoospermia. And in patients like this, with a full and firm epididymis bilaterally, you could either try reconstructive surgery or go ahead for surgical harvesting. And surgical harvesting and ICSI gives fantastic results. Now, if the FSH is low and the LH is low and the testosterone is low, they have hypogonadotrophic hypogonadism. I'll tell you the treatment of this. Or if the FSH is high and LH is high and the testosterone is plus minus, these patients have non-obstructive azoospermia. Please go ahead, do a Y chromosome microdeletion and plan a retrieval for them. In case there is low FSH, LH and a high testosterone, which happens so many times, these patients are taking anabolic steroids. Gymnasiums are crazy places. They give big bodies and small testicles. And most of these men with large bodies who have taken hormones, because most of them do, it's a part of bodybuilding as the way people do it in gyms. They are impotent, and not only impotent, these men also have low sperm count and in fact at times are azoospermic. Now, hypogonadotrophic hypogonadism, let me talk about this. In hypogonadotrophic hypogonadism, there is a low LH, low FSH, and in these patients, you are going to give them HMG and SCG. HMG is equivalent to FSH and SCG is equivalent to LH. So I'll just talk about the very interesting case I got. This lady came into my clinic. I had known her for a long time, a very rich lady. She said, where can I buy the most expensive sperm from. So I asked her why. She said, well, it's somebody whom I know, and he doesn't have a sperm, and I want the most expensive sperm of the world. So I saw the reports and examined and saw that the testes were low in volume, about 4 to 6 ml. FSH was low, LH was low, testosterone was only 72. So I told her that, well, I don't know whether it's going to be the most expensive sperm, but the best sperm for you is going to be his sperm. So this was about, I think, it's been about 11 years now. So we started HCG, and once you start HCG, you monitor the testosterone, and you want the testosterone to be in the normal range. And once the testosterone is in the normal range, you start HMG for them. And we started HMG in the 14th week, and bingo, we got sperms in about 4 months. But we got very few sperms, and we planned to go ahead for an ICSI. We did the first cycle, and she didn't get pregnant. We transferred in the second cycle, and the second cycle she had triplets. So we had to reduce. And finally, she had quadruplets. That's correct. I remember. And we transferred 4 because at that time we were not very sure whether she'll get pregnant or not. And we reduced, and finally she had these 2 healthy twins. And after that, we have had such a large series of patients with hypogonadotrophic hypogonadism, and they are good. At times their sperms are so good that they could naturally conceive. So and you know, more than that, these men who have no hair, they suddenly start developing the male form, and it becomes tremendous for them to feel like men. In fact, once they've had their babies, you could put them onto testosterone for a long time, but a lot of them choose to still go on with HCG because they feel that the testosterone is being made normally in their testes. They feel so comfortable. So now you have a lot of techniques of sperm retrieval, which I'm going to talk to you about. And sperm retrieval could be PISA, percutaneous epididymal, microsurgical epididymal, which is MISA. It could be a TISA or a TEFNA. It could be a TISA where you operate and take out the sperms from the testes, or it could be a microsurgical excision from the testes. So now I very simply, from my own experience and the videos which I have, would like to explain to you what it is exactly. Now, if a patient has sperms in the epididymis, you can take out these sperms from the epididymis and use them and freeze them to give them babies. And that's the way it appears to be. So the technique normally is that you could use an insulin syringe, a 24 gauge needle with an 1 ml syringe. You take some media into the syringe. You need to understand 3 things for this. You need to hold the epididymis fine, and you need to go into the most prominent area, or the most, I would say, turgid area of the epididymis. Once you have done this, goes to the lab, and in the lab they tell you whether sperms are present or not. This would be a PISA. Now, this was a patient who had a lot of azoospermic. In a PISA, sperms were not found somewhere. Patient came to us, we opened, and if you realize over here in the epididymis, you have all this inspissated, thick, turgid epididymal tubules. So I took a video of this because I was very lucky to get a video like this, which I wanted to show you. That this is how the epididymal tubules in obstructive azoospermia may get filled up. And in this patient, if you opened up under a microscope one of the tubules, and you sucked out the material, you would get loads and loads of sperms, out of which you would get a good percentage, or it may be a reasonable percentage, which you could use and freeze. Now, at times, you do not get sperms by an insulin syringe. So what do? In this condition, what you normally would use is a butterfly, and you would normally use a 21 gauge butterfly with a 5 or 10 ml syringe. You would give suction, clamp the tube, remove it, and take out the material which you have. Now, this material would be there where you are going to see if sperms are present or not. Now, at times what happens, now this is for obstructive azoospermia, but at times what happens that you may want to do in obstructive azoospermia, the hormonal level is fine, the testicular size is fine, you have not got any sperms by PISA, and you would like to use a needle to take out the sperms from the testicle. So for this, what you normally would do is take in a butterfly of about 16 gauge, take a 20 ml syringe, put the needle inside, try to mince it inside with the needle and pull out whatever material you can. Now, see, we are two things for us to understand. TISA is not the best procedure in non-obstructive azoospermia. But TISA can be used in case you have an idea that there are sperms in the testes in obstructive azoospermia and you have got nothing with a PISA. Well, I wanted to show you some interesting data because this is important. In case it talks about the sperm retrieval. Sperm retrieval in obstructive azoospermia is in tune of between 95 to 100%. And most of these men are young with young wives who at times do not have any comorbidity. Therefore, the results of FICOG in these men is fantastic. Obstructive azoospermia, men deserve their own babies. This is a very beautiful study by STVs. And Sandro did this amazing study in which he compared an ejaculated sperm to an epididymal sperm. The fertilization rate was about the same, the pregnancy rate was about the same, and the miscarriage rate was lower. Why? Because the DNA fragmentation of an epididymal sperm is less than an ejaculated sperm. So the results of this are good. Now, ICSI outcome in obstructive azoospermia compared to fertile donors. The comparison is such that, in fact, even if the best donor is taken compared to obstructive azoospermia, the results of 2P fertilization, high quality embryos, clinical pregnancy, and live birth is about the same. Now I'll talk about non-obstructive azoospermia. Non-obstructive azoospermia is like this apple tree. There is little bit of spermatogenesis at different areas. So it's a tree, it's a testes in which at a few areas you have areas where you have spermatogenesis. But it is not everywhere. So you have to go to those areas to get the sperms. Now, it could be by either doing a window extraction of the spermatozoa, where you would do make a small window, take this out, This normally is put for obstructive azoospermia, but this is the first line which we normally would do. This would go to the laboratory. It's going to be processed over there to see if any sperms are there. And if sperms are not there, then we proceed further. So you could, if you do not do micro-TSA, you could do testicular biopsy and sperm extraction. So in multiple, what you do is that in a patient, if in a single biopsy there is not there, and you are suspecting that the patient may have a non-obstructive azoospermia, which means there would be spermatogenesis at a few places, then you would take multiple biopsies from different places. And these you would then send for processing and find sperms in them. So this is one method which could be used as a multiple biopsy, as a sperm extraction technique. So once you have a specimen like that, what do you do with it? So you need to strip open the tubules. And once you have stripped open the tubules, the sperms are going to come out. And these sperms which are going to come out would then be processed and used for ICSI. You know, the most gratifying thing of these procedures is first to get the sperms, then to see the embryos, then to see the heartbeat, and finally give them children, because these children are priceless. So if you see over here, this is how it appears to be. And in this, then you look for sperms. Now, I have spoken to you about PISA, TISA, multiple biopsies, but there is something which I want to talk to you about, which I do in a few patients. We've done patients of Klinefelter syndromes, given them babies, post-cancer survivors, patients who have very high FSH, maturation arrest, hypospermatogenesis, and obstructive, of course. We've done so many. But the bottom line is that the most important thing in this is the counseling of the patient, which I'm going to share with you. Why? Because in this procedure, there is nothing but transparency and truth which you have to give to the patient, especially in non-obstructive azoospermia, where you may not even retrieve the sperm. Now, what is needle mapping? In a lot of patients, we may like to do a needle mapping, in which what we do is we plan about 16 areas in the testes from where we would like to take out the sperms. And as you see over here, once we have put the needle, just like a TISA, pulled it out, got a sample, we would take this sample out and place it in the Petri dish on one of the drops which have been labeled. And in case we get sperms from a place, we're going to enter that place to get sperms further from the tissue. But at times the amount of tissue which we get in this could be less. So what we normally do is a TEFNA procedure. So in this, what we do is we have marked out 16 places. And once we have marked out 16 places, there are 8 above the equator and 8 below the equator. Once we have given suction, see what happens is a tubule normally gets extruded. Now, if with a microforceps you get hold of this tubule and you pull out the tubule, you get a reasonable amount of tissue. Now, you take this out from 16 different areas, and the place where you get sperms, you enter that area. So it's less traumatic than a lot of other procedures for the testes. And this is how we would do a TISA mapping of the testes. But you know, the procedure which is today the gold standard is micro-TISA. And it, of course, was popularized by Peter Schlegel. And I had the opportunity of meeting him. And the beauty of this procedure is that you open up the whole testes, you bivalve the testes. And when you bivalve the testes, you under a microscope, operating microscope, look for tubules which could be thicker. You pick up those tubules, and in those tubules, you search for sperms. So this is micro-TISA surgical technique. This is extremely gratifying in non-obstructive azoospermia. So you first open up the testes, and before you bivalve it, you normally would like to see if there are any tubules which are thicker, and you would like to take out, if there is anything which you see, you need to scan the whole thing. And once you have scanned and you feel there are any tubules which are thicker, look different, you would like to pick up the tissue from that. And after you have done this in the first layer, if you find sperms, fine, you would close it back. But if you do not find sperms, you would go ahead and bivalve it. And you open up the whole testes. Once you have bivalved the testes, you would be able to get from different areas tissue. And this closes back beautifully. I mean, you feel that you made a flower out of the testes, but that's not the way it is. You're able to close it back beautifully. And from this, you would get the sperms to give them children. This is how it would appear to be in an area. This is how normally it would appear to be in a PISA sample. As you can see over here, there are all RBCs over here, and you're looking for a sperm. And this is a very old video, so the quality of the video is the way, because I think about a 10 or a 12-year-old video which it made initially. So you find a sperm over here, you pick up the sperm, just on the lights, you pick up the sperm, and generator chalwa de. You pick up the sperms. You pick up the sperm and you go ahead and do an ICSI. So that's an ICSI in this patient. Now, the key message is that in obstructive azoospermia, sperm retrieval and lab processing is simple. Sperms obtained in virtually all cases. Chance of sperm retrieval and ICSI outcomes are fantastic, independent of obstructive etiology, independent of retrieval technique, independent of sperm source, and results are similar or better than ejaculated sperm. But in non-obstructive azoospermia, sperm production is deficient or absent. Overall retrieval rates are about 50%. It's labor-intensive lab sperm processing. Retrieval is dependent on technique, Y chromosome microdeletion, predictive factors, testes histology, and Y chromosome. And reproductive potential of ICSI in obstructive azoospermia is much better than non-obstructive azoospermia. Now, this is something which I probably will not cover, but yes, in patients who have a lower testosterone, we normally would give them clomiphene and anastrozole or HCG to bring their testosterone level to normal so that we could go ahead and do a retrieval. Now, the future, what are the prospects? The future prospects are that a few sperm biomarkers are used as diagnostic and treatment tools. The prospects of male fertility preservation are fantastic. Stem cells is a new agent for treatment of male infertility. And with genetic testing and current diagnostic tests, there is a still large proportion of idiopathic non-obstructive azoospermia, obstructive azoospermia cases who are likely to be affected by undefined genetic factors. And Genesis and pre-TSA program is going to really help. So now, in a nutshell, I will just show you what the future is. Genomics, transcriptomics, proteomics, metabolics. Whenever some protein is made, it leaves behind a few proteins around. If you can detect those proteins, you would come to know whether spermatogenesis will be possible for this man or not in the future. So, before doing a TSA, if you could do a test where you could know that I'm going to get sperms in this patient, wow, that would be fantastic. So that is where the world in investigation will go ahead in the next 10 years. Now, this is a very interesting slide I want to show you, that in the future, when stem cell technology develops, if there is a person who has testicular or any kind of malignancy, you could either store his sperm if he had sperms, but if he does not have sperms, you could take his tissue, and in the future, the tissue could be transplanted into a mouse to make a sperm. It could be organ transplantation. I mean, culture could be done to get, or it could be transplanted into the man again, or the boy again to get sperms. So this from the tissue would be getting sperms from the spermatogonial stem cells in the future. Or you could get the spermatogonial stem cells and you could culture them, either transplant them, or after culturing them, get sperms. Or you could do a skin biopsy, and from the skin biopsy, take those pluripotent stem cells and make them into haploid cells as sperms. So the future would be in an area where there'll be so many avenues which would be looked into. Today in these COVID times, we plan a vaccine within a year, and the world is working towards it. Do you know that vaccines before this were developed in up to 28 to 14 years? The way technology is going today, those azoospermic men in which sperms cannot be got would get their sperms. Now, spermatogonial stem cells is something which, if taken from the tissue biopsy, there could be in vitro proliferation which could be done to get sperms from them. But you know what the future prospects are? You could either do a transplant in the same man after taking out the stem cells, or you could xenotransplant them and multiply them. Genomics could be used, or in the future, in vitro generation of sperms could be done. There are no sperms, you take out spermatogonial stem cells, you in vitro culture them into sperms and use those sperms. And can you imagine what has been done till now? In rats, spermatogonial stem cells have been taken. They have been cultured into stem cells, into sperms. Mice have been inseminated with those sperms, and mice have been born. It has not been possible till now in humans because that particular culture media has not been developed, and it is a bit complicated, but it will be in the future. Now, do we know what CRISPR is? I think a lot of people know. If you know, just type in IK. And if you want to know, just type in BIO, bring it on, because this is extremely interesting. Till now, gene editing was a very tough job. But what happens when a virus gets into your cell? A virus replicates the DNA. Similarly, keeping this in mind, CRISPR was developed where a gene sequence was replicated and replaced. So in the future, from an embryo, for parents who have thalassemia both, the gene of thalassemia could be removed, could be replaced with a normal gene, and the babies would be born without thalassemia. Similarly, it could be done for diabetes, but something interesting could happen in the future. A man could say, I don't have a wife like Katrina Kaif, and gene editing could be done for the daughter to get a daughter like Katrina Kaif. The man says, I wanted to be Sachin Tendulkar. I would like to have a son who is Sachin Tendulkar, and gene editing in the future could be done. But this ethically probably will not be possible. Otherwise, all the toppers of NEET and all the toppers of the class 12th would be designer babies. And all the great athletes in the world, be it cricket or be it hockey, would be designer babies. But this technology is developing extremely fast in the world. And today this technology has reached a place in the United States and China, where in the next 10 years, you yourself are going to see the magic of CRISPR. The next revolution in this world will not be in iPhones or in computers. It is going to be in human biology. And that's the beauty of our line. A beautiful slide, because I just want to share something light with you. Today, if a man and a woman have a child, man gives the sperm, the woman gives the oocyte, you have a baby. Today, if two men want a baby, what do? One gives a sperm, there is an oocyte donation, and it's kept in the surrogate. So a coin is ticked up, you give the sperm this time, and I give the sperm next time. But in the future, from a pluripotent stem cells, and oocyte will be made from one man. Sperm would be taken from the other man, and a baby would be born, which would genetically be a baby of that couple. And if there are two women, one would give an oocyte, and the other is going to give a pluripotent stem cell from which a sperm would be made, and both would have a baby, and it would be kept in one person's womb to have a child. But there is a catch in it. These two women will only get baby girls. So I would end over here, and thank you very much for being such a lovely audience. And in case you have any questions from Dr. Nandita and me, we would be so glad to answer them for you. Thank you very much.
Superb talk, Sunil.
Thank you so much, ma'am.
I think Dr. Sonal is trying to.
Fine, sir. Thank you, sir, for the wonderful talk. And our viewers have 100% benefited with your talk. And there are many questions in they have put on the chat box. I'll be taking some of them. First of all, I would like to share their appreciation for both of you. They have appreciated that both the talks were very wonderful and having practical insight. And there are some questions to Nandita ma'am. They are asking when estrogen pre-treatment given for 7 to 10 days, if the patient doesn't get cycles, how can we start gonadotropin, or shall we prolong the estrogen till day 1 of the cycle?
Normally, we give it till day 1 of the cycle.
Correct. And the other question is how to increase oocyte quality in poor responders.
Yeah, that's a tough question, but basically, if it's a younger patient, I think age is quality, so it really helps. And if you want to get good quality in an older patient, the trick is to get more eggs. You know, if you get 10 eggs, at least 3 will be normal out of it. In a 40-year-old, in a 42-year-old, you should get 15 eggs. So you really have to work very hard to get all these eggs. And it's a matter of statistics, I think. So I must tell you the story about this patient of mine who was 42. Her AMH was 0.5, and she came to me, from another doctor who had told her egg donation. Okay, and she came to me and she said, I don't want to do egg donation. I said, okay, if you're willing to fight, we'll fight. And we did 5 pickups and we got something like 8 embryos. She was 42 years old, okay, in 5 pickups. And we put in 3, just morphology. I didn't do anything much. Embryoscope, polar scope, that's it. No genetic testing. And she conceived in the first shot. So it is statistics, you know, out of those 8 embryos to get one which was normal. So I think the number matters in poor responders. So you need to really persist and get more eggs.
That's wonderful, ma'am.
And of course, add DHEA, add melatonin, add RG prime, add CoQ. You know, even vitamin D is something that I add to a lot of people. Okay.
Correct, ma'am. There is a question to Jindal sir. They are asking, please mention clinically as how you will evaluate a male step by step.
Oh my God. I think that's a whole lecture they want from me.
Yes.
Yeah.
No, I think before this, there was a lecture which was done for this evaluation of the male. And in the future, we probably could have another step-by-step evaluation of the male, which would be very useful. I would agree. But evaluation of an azoospermic over here, I had given the algorithms, 2 algorithms, which in case you are able to, we'll have your data. So we'll also send you the algorithms so that we could do for you.
Correct, sir. Question to Nandita ma'am. Will you go for fresh ET in all cases of poor responder unless you plan for embryo pooling? Or what are the criteria based on which you plan for frozen or fresh ET?
See, my frozen embryo transfer success rate is very good. And also it's convenient for me. And I actually go for, as I said, the more number of embryos that you get, it's better. So what I like to do is a frozen embryo transfer. I collect all the embryos together and transfer. There are certain cases where I do fresh embryo transfer. If supposing the embryo is genuinely fantastic in a young patient and the endometrium is superb, you know, I've been told that, madam, this endometrium is too good, you have to transfer. Okay, so the endometrium is really superb, then I may transfer in such patient. Sometimes embryo is not good, it's not even worth freezing. So then I would like to transfer it and just give her a chance. Because in my 25 years of practice, I have seen good embryos give me babies, bad embryos give me babies, all kinds of things. So I don't like to throw any genetic material away. So I think that's something that you can, I would like to do. But frozen transfer is the way to go.
Correct, ma'am. Again, question to you, ma'am. Will you start recombinant LH or HMG in all patients with poor responder? And if so, 75 IU or 150 IU?
Okay, in younger patients, I usually continue recombinant FSH only, but I do add recombinant LH. So it would be like, I think 300 and 150. 300 of FSH and 150 of LH.
Question to Jindal sir. Sir, they are asking, how do you treat hypogonadotrophic hypogonadism patient? Means what is the HMG, HCG dose and duration?
See, it's a very simple thing. The dose of the HCG and HMG is related to the weight of the patient. Normally, what we do to a patient who is less than 60 kilograms of weight, we would give these patients about 2,000 international units of HCG twice or thrice a week. We're going to monitor these patients with the testicular size. The testicular size is going to improve. And we would do a testosterone of these patients. Normally the testosterone of these patients is low. So we will see the testosterone of these patients. Once the testosterone comes to the normal range, we would start HMG for these patients, given 75 to 150 international units twice weekly. And once we start giving both of these together, we're going to wait for about 4 months. And normally within 3 to 4 months, about 60 to 65% of these patients are going to give sperms and good sperms. So this is the methodology which we normally follow. But there are two things for this. We give HMG because it's cheaper than FSH. You could even give FSH. You could give recombinant to these people. And we give HCG normally throughout the process, which it would be. At times, we need to increase the HCG because the quality of the HCG at times may be such that we may increase it based on the testosterone, which we get of these patients as a report. I could probably send you an algorithm, and this algorithm of, it's a PDF which I have, I could send you, but you'll have to send your number on 800-6666-085. If you could note down, could you put it into the chat, please? Vinod, if you could put this number into the chat, 800.
Yes, sir.
800.
Just give me a moment, sir.
Yeah, 800-6666-085. So an algorithm which would send you an algorithm to follow for, and madam, if we could get a small algorithm from you, we could just create a PDF and send to everybody. I think that would be very convenient for them.
That would be good, I think.
So just note down this number, please, and just send your number and your name. I hope you have noted down the number. And Vinod, please ask the support people to put it in the chat box. I put it into the chat.
Okay, sir.
Nandita ma'am, there is a question for you. Can we give testosterone gel with OCPs?
Yeah, you can. There's no problem.
And another question, poor patient age 35 to 40, low AMH, when they opt for IUI, how many months can we treat them with testosterone?
Oh, wow. I don't use testosterone for IUI. I'd rather use DHEA because that's easier. Testosterone, I would stick to it before IVF.
Correct.
I have not read or heard of any studies of testosterone before IUI. So I guess.
Correct. So mainly it is in IVF.
Because long-term testosterone can be very traumatic. You know, it can cause a lot of hirsutism, acne, etc. So you should not be using it for too many cycles.
Ma'am, they are asking, what about increased incidence of aneuploidy if we take own eggs in women more than 40?
No, that's what. See, the aneuploidy, that's why the pregnancy rate is lower. So in a 40-year-old, at least 2 eggs out of 10 will be normal. Okay, so we have to target those 2 eggs. In a 42 plus, there'll be 1 out of 10. So the incidence of aneuploidy keeps increasing. Definitely, there is no question about it. That's why you need numbers to overcome that problem. So 10 में से अगर 2 normal है, तो you can use those 2. You know, the 8 will not give you a pregnancy, but those 2 may give you a pregnancy. That pregnancy rate of those 2 embryos will be nearly 60%.
Correct, ma'am. So there is the importance of number of eggs you retrieve.
Yes.
And right, ma'am. And there are many questions coming in, but because of time constraint, I'll be thanking you. And before I conclude, they are telling congratulations to Nandita ma'am and Jindal sir, and they are wishing happy birthday to Jindal sir.
Yes.
Oh, thank you very much. Thank you so much.
I can't believe it. You let me fix a day which was your birthday.
It's great fun. It's a party.
It's a party, yes.
So on behalf of INTAS and all the viewers, I thank you, both of you, for giving us the wonderful and insightful talks.
So Sonal, we'll see you after 2 weeks with our next topics.
Fine,
Right?
ma'am. Sure. So it is a unique series of webinars.
And 15 days from now, I would like to just mention to all the people who are here, we'd like to catch you here because Madam is going to speak about recurrent pregnancy loss, which so many people have, and it needs to be solved. And I would be speaking about the male factor of recurrent pregnancy loss. So it's going to be very useful. And please take the number, put it in, send it. We're going to send you, Madam and I are going to send you a free PDF of the algorithms which you could use for your patients. Thank you very much.
Yes, sir.